My name is Dr. Priya Shetty, and I've been working for the past several years with Dr. Achilles Katamba and the group at the Uganda Translational Implementation Research Consortium in order to build models of study and research to improve patient access to care and improve health system performance related to TB. So I'd like to take you through a little bit of a chronology of how I became interested in this topic and why I think social determinants and social protection are intrinsically related, as you well know, to quality of TB care. So the goals that I have for today are really to present some background and rationale for why these social determinants and social protections are critical. And then, perhaps most importantly for this group, to present a review of some of our research and the methods we've employed to begin making some recommendations in how to evaluate social protection and how to implement social protection in this context. I always like to start these sessions with this slide. And I usually am speaking in a symposium or in a workshop where primarily we discuss biomedical interventions for TB, the very important need for better diagnostics, shorter course therapy, better trials, things of that nature. And this is just a reminder that those things are all very important. But as you well know, fundamentally TB is still a disease of poverty. And what do I mean by that? We have a lot of data from over 50 years showing the social and structural determinants that cause TB in populations. They're related to national health expenditures, human development index. As those things go up, TB goes down, incidence goes down. As household income goes up in countries, TB rates go down. As sanitation is poor and nutrition is poor, there you see TB incidence increasing. Not only is TB caused by poverty, but you know it perpetuates poverty. Countries with high incidence and high burden of TB often lose an average of 4 to 7% of their GDP, their gross domestic product, and that translates to 3 to 4 months of lost productive work for patients and families affected, as well as we've been hearing about already, the catastrophic costs associated with TB care. So how are we addressing this? Well, the policy world has taken a head start. This slide is really meant to show that ending TB requires us to think about TB in the context of the Sustainable Development Goals. And that broad spectrum of agenda items covers not only health, which is SDG goal number 3, but also no poverty, decent work and economic growth, reduced inequalities, and collaborations, multisectoral collaborations. And so from a policy perspective, I would argue that we've already decided that TB is now a multisectoral disease and merits multisectoral interventions to fight it. Here in Uganda, as already been mentioned, that's already a mindset that not only NTLP, but other government officials are thinking about. And keeping everything in context with the NTB strategy. Number 1, patient-centered approaches. Number 2, supportive, bold policies and systems. And of course, research to inform those 3. But here in particular, there's been good support for costing studies to inform catastrophic costs as an indicator, and we're all excited to hear the results of that, and to improve research and policy on patient social and economic barriers to care. So how did I and we as an organization at UTR come to be interested in this problem? Well, first, I came to the world of TB thinking mostly about diagnostics, the advent of expert scale-up, and what does that mean for health systems and for patient access? Well, it turns out that patient attrition in Uganda in the TB cascade of care fundamentally is quite poor. And this is a result of several studies that have captured the standard of care for patients trying to reach TB diagnostic services. And I'll just take a moment to say that for the duration of this talk, I'll be focusing not on the full spectrum of TB care all the way through to treatment completion, but rather focusing on what we found to be the primary and largest gap, which is pre-treatment loss to follow-up. So that's a much smaller part of the TB patient cascade of care and the focus of this talk and our work. So what we see here is that we looked at almost 1,800 adults that were undergoing TB evaluation for symptoms consistent with TB, chronic cough primarily. and found these indicators, that the proportion referred for sputum-based testing was about 80%. The proportion, if referred who completed testing, is about 60%, and the proportion who were then treated or initiated treatment within 14 days, if microbiologically positive, around 70%. So what does that mean for one patient who has TB who shows up to the facility? The cumulative probability of being diagnosed and treated is only 35%. So that represents a significant gap in our ability to provide care for patients. And what was interesting about this study is that 25% of patients were referred for expert testing. And these results will be, they're actually in submission right now. And 45% of those who were expert positive initiated treatment within 14 days, meaning that 55% didn't, who had what we think of as a point of care test, didn't get started on treatment in a timely fashion. That to me was a very shocking result of the study, and we wanted to understand why. So the two possible players in this picture are the health system and the patient. And so we conducted a study called a simple TB study to demonstrate what would happen to these gaps if we restructure the health system and improve provider self-efficacy in providing quality TB care. And what we found is that the cumulative probability increased to 84%. But that we really found that, and sorry, this is a mistake, that 25% of expert positive patients didn't initiate treatment. So that's an improvement from before. But still, that's 25% who did not initiate treatment, even after significant health system restructuring in peri-urban and rural clinics. So why is that? And I would hypothesize that the reason is because of some patient barriers to care. So we sought to document what those pathways and barriers could be in the very first steps. This is a study that we published in 2015 that is a very colorful and challenging slide to read. So please don't make yourselves dizzy trying to follow these pathways. But it shows to demonstrate in a sample of community and clinic-based patients who were surveyed where they went for care when they had symptoms of cough. And what we see here is that they went everywhere. And I'll show a little bit more detail about where those places are. But they had an average of between 3 to 5 visits before they reached level 4 health center, which was the first place they could reach TB microscopy services. So what do all of those visits mean? We know that the patients have been very busy in trying to find diagnostic care. And so here we list out by visit 1, 2, 3, 4, up to 5. And over on this side, we list the providers: herbalist, pharmacy, health post, hospital, private clinic, health center floors. And we map these paths of where patients go and in what order. And what you see just kind of grossly is that ultimately everyone kind of ends up at a health center. But it takes them many, many visits, about 5 visits to get there. And we also marked the types of health centers that were visited for all of these visits. And what you see is that private clinics were very close to level 4 health centers when it came to how many visits patients went to for seeking kind of comfort for their cough and diagnosis. But when you add pharmacies and herbalists with them, basically the public and private sector is seeing very similar numbers of patients. So we know that our patients are very busy. They're spending money in the private sector, and they're obviously ending up, thankfully, in the public sector. But what did that cost them? So we further conducted a costing of accessing TB diagnostic care. So this is among patients who are presenting at a level 4 health center to submit sputum for the first time. And what we found, and these just represent the indirect costs, not the direct costs at all related to care, but the indirect costs. And what we found from our study is that patients just to submit their sputum sample were spending 29% of their median monthly household income, which by our definitions is catastrophic, right? What we talk about is that 20% of your median monthly household income spent on TB or any health-related kind of expenditure bodes poorly for your treatment and your outcome. And what we're demonstrating in this study is that even before they are diagnosed as having TB, people with chronic cough are reaching catastrophic thresholds. So we further wanted to understand more the socioeconomic consequences of these pathways to care. And so most recently have conducted a cost and what we call the Cost and Social Protection Survey, which occurred at 24 health centers throughout Uganda. And you can see, I hope it's not too blurry on the map, the relative distribution around the country and around Kampala. And this was a cross-sectional survey of 468 patients, facility-based, who are presenting for their initial TB diagnostic evaluation. So at the time they are submitting sputum for the first time, they were administered this survey. And this occurred between June and December 2017. So I'd just like to take a few minutes, and in addition to emphasizing that this is pre-diagnostic, we don't know yet if these patients have TB, the differences between this study and the study that our colleagues have conducted here at the national level. We weren't looking for patients who had MDR or who had any risk of MDR. We had assumed based on the literature those costs would be significantly different and wanted to focus only on drug-susceptible TB for patients who are presenting for the first time with chronic cough. But we did use the same or very similar tool. So we adapted our tool from the WHO 2017 patient costing survey. And here are some of the things we found. So some patient characteristics. Nothing too surprising. About half were women. The median age about 37. About half were HIV positive. As with other similar studies, we found a household size of about 5. We found that 58% of the patients were already living below the poverty line as defined by about $1.9 US per day. And we found that these patients had had a duration of symptoms of about 3 weeks. We also found, as we imagined based on the characteristics of this group, that they had limited education, the majority having completed primary school or no education. A handful had gone to university or graduate school, but not very many. And then in terms of employment status, the majority, the vast majority, are employed in the informal sector. So this table is just to document some of the socioeconomic consequences that we showed as a result of TB-related symptoms. Again, these patients haven't started therapy, they haven't even completed diagnostic testing or returned yet to the clinic for their tests. But just because they had chronic cough, we demonstrated a change in individual income for that patient of 40%. The change in the household monthly income was decreased by 24%. And the number of households, a proportion of households who were living below the poverty line increased by 10% to 68%. What's interesting to me is that I didn't mark it in red, but the cost of the current visit alone was 17% of the median household monthly income. So remember, if we're thinking about the threshold of 20% as catastrophic, even before they're diagnosed, these patients are hitting close to the threshold for catastrophic costs. And then the number, and I'm sorry, I think this was a mistake as well, the number who experienced dis-savings was about 42%. And that's really important because in some circles we're trying to think of whether or not experiencing dis-savings is a better marker or better predictor of poor treatment outcome or poor outcome overall than catastrophic costs. And then I always like to discuss this last statistic because I think it's very important that the number of households who disenroll a child from school because of the costs they're facing is 9% in this population. And the reason why I think it's important is because we're thinking about poverty multi-generationally. So what happens to our patients today doesn't just affect our patients today, but affects their children next and their next generation, and so on and so forth. What I think was very interesting here is that only less than 1% of patients receive any social protections whatsoever. And that means health insurance, disability benefit, microfinance loans from their community, things like of this nature, food baskets. So social protections are not very used at all in the Ugandan setting. And then self-reported stressors was also very high. So 64% of patients thought they had a significant financial impact and socioeconomic impact as a result of their symptoms and their quest for care. So now I'd like to focus just for a moment on the social consequences solely. And I think we think about social protection and socioeconomics mostly in the financial terms because they're easier to measure. As hard as it is to calculate these costs, it's a number we can measure. But here we see from the questions we'd asked of patients, did you have any social consequence as a result of your chronic cough and seeking care, TB care? 68% that they said they had suffered from social consequence. And of those 68%, you can see the breakdown, with the most important being stigma. There's still a lot of stigma involved in TB, and it's really becoming a social barrier for patients in trying to live in their communities and seek out care. Also, I wanted to highlight that symptoms of depression and other psychosocial indicators were reported by 17% of the patients. And I think the important factor for us as clinicians is what, and public health practitioners, is what does that mean? It means for us that 41% when asked said they wouldn't go for any additional evaluation or testing. So when we look at our patient attrition in the cascade of care, we now have a reason fundamentally for why that is. They're suffering very significant financial and social barriers. So what do we do? And this concept we've been talking about a little bit, social protection, isn't the answer. So first, because this was an area new to me until the last 3 years probably, as you mentioned, that it's something that we talk about in the TB world. I'm not a health economist, I'm not a sociologist. I had to learn these things a little bit. So social protections are really called any interventions that address an individual's social and economic risk. And beyond an individual, I would say a household's social and economic risk. And this can include things like health insurance, disability benefits, food baskets, microfinance, cash transfers, social support groups, I think is an understated but important one as well. So the fundamental question for us as researchers is now, can social protections enable behavior change? Meaning nudge a patient into doing something that they didn't want to rationally do before because of some barriers. Or can it outright just improve outcomes, either through poverty alleviation and income supplementation, or by affecting health outcomes? And I think for us as a TB community, the way to really engage with this discussion is to consider whether or not TB-specific interventions, meaning those social protections that are offered only to people who have TB, or if advocating for general social protection interventions in our communities is the best way to achieve some of these goals. So how can it work? With the help of social epidemiologists, we have a framework to demonstrate the indirect and direct effects of social protection strategies fundamentally on the entire spectrum of the TB cascade of care. And this again is probably your third and last busy slide of the talk. But I think it's important to highlight that some of the indirect effects of social protection strategies can include things like better education, better access to social and health services, better food security, things like this. And that the direct effect of income can overcome barriers to actually getting a patient to the clinic, overcoming those conditionalities that are preventing them from returning that we described in the previous slides. And so how we imagine an intervention to work really depends on how we think about it in the context of this framework and which of the intermediate effects of health-seeking behaviors, individual and household food security, biological risk factors, and social and structural risk factors we want to address. So this all seems very complicated to me, and I'm not sure exactly how to go about developing an intervention to do that. Turns out I'm not alone, none of us are, that social protection in TB doesn't have a very long track record. That we have seen through programs in other countries where there is a more robust social development system, like Brazil, for example, where they have a national conditional cash transfer program for people who are in the lowest quintiles of income. They've shown improvements in maternal mortality, nutrition, and perinatal mortality, as well as an under 5 mortality. There's limited data for use in TB, however. There's been one trial so far that showed improvement in economic outcomes of cash transfers plus social support in Peru. And that demonstrated a 29% decrease in the number of households affected by catastrophic costs. The other two trials that were done in South Africa, were related to TB treatment adherence. And they were stopped early because of poor fidelity of implementation of the study. It was a cash transfer study where nurses and clinics were supposed to screen patients for poverty and then give cash transfers to those patients on treatment who they thought highest risk because of their poverty. Turns out that nurses they thought they could identify which patients were higher risk without the steady protocol, and were giving the cash transfers, it turns out, to the patients who weren't actually among the most poor. So the fidelity of implementation was a critical component that failed in that study to show an effect. So I think a question for us as a community here working on this in the Ugandan context is how can we provide more concrete evidence to scale social protection and interventions here without falling into some of the traps that have occurred in other studies before. So I'd like to present to you a study that's in its early stages and ongoing through the UTURC, the Uganda Translational Implementation Research Consortium, called EXACT-TB, evaluating the impact of cash transfers plus on TB care. There are 3 aims of the study, and it's all taking kind of the background work that I've described thus far and trying to go one step beyond and make sure we can come up and pilot test a social protection intervention that specifically targets the barriers that our patients are facing in the clinics in which we serve. So the first aim is to identify the modifiable social barriers to completing TB diagnostic evaluation. Again, we're focused here on that initial big gap in the cascade of care. The second aim is to identify some incentive-based strategies that can overcome the well-documented economic barriers to completing care. And the third is to test the feasibility and potential impact of the social protection intervention. So aim 1 of the study is to conduct up to 50 in-depth interviews with patients, again, who are presenting for TB diagnostic evaluation because of chronic cough in 24 health centers in which the UTURC studies are working. And these interviews are based on the WHO social determinants of health model, where we ask questions specifically addressing each of these components: socioeconomic position, but also material circumstances, biological factors, and psychosocial factors, such as I discussed in one of my previous slides, where psychosocial factors seem to be a large self-reported consequence of having this chronic cough and seeking care. With these interviews, we hope to identify some social barrier that we can actually modify with an intervention. Aim 2 seeks to identify an incentive-based strategy that we can supplement with a social support strategy to improve patient access. And so there are 2 parts of this aim. First is an ongoing set of studies to look at patient attitudes and perceptions of incentives. We surmise that because social protections are not very readily used in this context, we weren't quite sure how something like cash transfers would be received by these populations that are affected. And so our team right now is conducting a cross-sectional survey of 50 patients with symptoms meriting TB diagnostic evaluation to ask questions about attitudes and perception of incentives. It turns out that, and we have small numbers thus far, so this is by no means final and representative, but right now we think about 1/3 of our patients have received a cash incentive before, and all of them thought it was helpful, self-reported helpful. We don't have data on the costs or whatnot related to the post-receipt of this. And this is not related to TB. They received cash transfers for other things entirely. 100% reported personal acceptability with receiving some incentive, which is not surprising given that the majority of our patients are living below the poverty line. And 83% believe that would be well received within their community. So maybe it's well received for me, but I also think it would be well received by my neighbors. Cash and transportation vouchers were much more highly rated than food baskets. And finally, transportation was reported as their largest self-reported barrier. So we think about the costs related to all these things, and we know that transportation costs are a huge indirect cost, as are lost wages. But for this, thus far in our survey sample, it seems that transportation is the most important. So in addition to cash transfer, in general, we want to be able to target the cash transfer in a way that actually nudges the patient to behavior change. So this is a framework that we've adopted from behavioral economics, and it's basically a discrete choice experiment, asking patients a set of rapid questions to find out what threshold of an incentive they think would be enough to get them over the hump of coming back to clinic. So this is an example of how one would work, where you would start with the patient and then ask them in random fashion, would you accept $1? Would that be enough for you to come back to clinic? Yes or no? No. Well, then I'll give you more. What if I gave you 5? Would you come back? Yeah, sure, I'll come back. Okay. Would you accept 3? It seems very salesman-like, but in reality, economists have been using this to match their interventions with the populations that they work in. So the idea is that we only give the incentive necessary to change thinking and behavior related to this. No more, no less, we hope. And if we come up with the idea that everybody wants $300 to come back to clinic, then first of all, everyone's very smart to say they need a lot of money to come back to clinic, but also it means that cash isn't the answer. Because we know from our previous work that to overcome just their income loss would be about $4 US dollars. So anything more than that means something else is going on that they require, and maybe that's social support. And so finally, I'd like to present the implementation research framework, implementation science framework that we will use to develop the intervention. This is something that our group has had a lot of experience with. Dr. Achilles and Dr. Aditya have used this PROCEED model many times before in some of our diagnostics intervention development. And so the process is really to take the barriers we identify and prioritize them with stakeholders and based on evidence review and feasibility, to select the interventions from among this menu, and to then specify how they're going to be delivered. And the way we would think about how to choose these interventions is based on this PROCEED framework, where we posit that there are predisposing factors, enabling factors, and reinforcing factors that elicit a behavior. So you can see that the predisposing factors in our case are likely things like socioeconomic status, stigma, psychosocial issues, material circumstances that predispose a patient to being able to come back to clinic. Enabling factors could be things like cash transfers or vouchers, and social support can be reinforcing. And so in this kind of validated approach, we hope to be able to build a more feasible and scalable intervention for testing. And the study will actually start later this summer to pilot test an intervention in 4 of our 24 network clinics for the next 6 months. So just in closing, some of our next steps. And these are next steps not just for the studies that I've been proposing and describing to you, but also for those who want to be more engaged in this work, that we really need to come up with better linked social, economic, and health indicators. What do these mean? How do we translate this? Why should a public health practitioner in Mbara, for example, want to ask their patient about income? We have to make it tangible and linked in a way that they think that they can do something with that information. There's a need, I hope I have suggested this to you, for more formative research describing these barriers and enablers for social protection interventions in multiple contexts. So not just in Uganda, but Uganda is also a great, large country with very different urban and rural atmospheres. So we have to be consistent in how we pilot these. And there's also a need for context-specific policy translation frameworks and research to support them. So in addition to doing the pilots and the quasi-experimental designs and the trials of this that we ultimately will do, how can we link that to translation? How much of these barriers can be overcome by universal health coverage versus needing TB-specific social protection? Based on our data so far, I would argue that universal health coverage is critically important in bringing people into primary care. But TB patients in particular suffer a lot more than most average patients and probably require TB-specific social protections as well. And finally, that we need to use our research and academic platforms to advocate for multisectoral approaches, including social justice and equity, to the benefit of our populations. So finally, I'd like to thank all of the people who've been contributing to this work. Many are in the room today. These are colleagues at UCSF, at Makerere, at the Yale School of Public Health, Johns Hopkins, and London School of Hygiene and Tropical Medicine, all involved with UTURC. And then especially I'd like to thank our UTURC research team led by Talamwa Nlugwa, and special thanks to Sarah Nawera, who's been leading the survey efforts that developed a lot of the results that I shared with you today. So thank you very much for your time.